Hello, and welcome to today's session of the National Undergraduate Urological Teaching Series. My name is Dr. Sayed Zaidi, and I'm an Academic Foundation Year 1 doctor based in the West Midlands Deanery, as well as being the President of Students for Urology, the National Urological Society for medical students, foundation doctors, and core surgical trainees. Today, I'd like to talk about hematuria. It is a common scenario that junior doctors are called to see, and so we believe it is important that juniors create a working structure to fall back on in this situation, as well as being able to formulate a plan that will ultimately be beneficial for the patient. So before we go any further, what exactly is the definition of hematuria? Hematuria is the presence of blood in the urine, either visible or non-visible. Some terms might be microscopic, as confirmed by the urine dipstick. So let's have a look at a common scenario that you might be called to see as a junior doctor. You are a Foundation Year 1 doctor working in the Surgical Assessment Unit. A 79-year-old man with a long-term catheter presents with a 2-day history of a very dark blood in his catheter bag and severe suprapubic pain for the last 4 hours. He has a background of atrial fibrillation for which he is on apixaban. We're going to discuss the causes, the emergency management that you might do in this scenario, and the general overview of how you might follow up this patient. So first things first, when you want to assess a patient, follow the ATE assessment. Now this patient typically would have come through A&E before being referred to the surgical assessment unit. They may have been stable in A&E, however that will only provide you a small snapshot in time. He could have possibly deteriorated since. And as the doctor on call, it is your responsibility to make sure that the patient is stable before receiving further treatment. So how might we assess him to make sure that he is stable while he's on the surgical assessment unit? As part of the ATE assessment, the first thing we're going to look at is his airway. If the patient in this case is speaking, then the airway is patent. He's speaking full sentences. He's able to be coherent of what his surroundings may be. Breathing. So in this case, the patient's respiratory rate was 18. You put on the SATS probe, it's 97% on air. When you have a listen to his chest, you find that the chest is clear and there's bilateral vesicular air entry on both sides. When you have a look at the patient's circulation, which is typically the biggest part of the AT scenario, you find that his heart rate is 105 but irregular. However, we know this because he has atrial fibrillation for which he's on apixaban. You have a look at the blood pressure. When he's lying, it's 120/80. However, when he's standing, it drops slightly to 110/70. Nothing too concerning and is somewhat to be expected. You have a look at his capillary refill time, less than 2 seconds. His temperature is noted to be a little bit on the high side at 37.9. And you have a listen to his chest. You can hear both heart sounds as well as no added sounds. You see his dehydration status, his mucous membranes, they're moist and well hydrated. Of course, as it mentioned, he was on a long-term catheter. You have a look at the fluid balance. The catheter bag is about 350 milliliters. You can see some blood-stained urine, but no clots inside. The patient reports consuming around 500 milliliters of fluid today. Of course, as you're assessing a patient, it's very important to see if there's any previous history on the patient. So in this case, you want to have a look at his FBCs, have a look at MCV, have a look at his INR, have a look at his CRP, as well as a whole host of other blood tests that might be useful. Having finished C, we're going to move on to disability and exposure. Now, the patient has a GCS score of about 15, so that means he responds appropriately to commands and is aware of his surroundings. However, talking to the patient, he feels a little lethargic, and when you look at him, he appears to be somewhat drowsy. This might be due to the case of his blood loss. You have a look at his pupils. You notice that the eyes are equally reactive to light, less than 3 millimeters, and you take a blood sugar, and you see that it's 5.4. You then move on to examine the patient's abdomen, to which you find suprapubic pain, but a soft abdomen otherwise, no obvious organomegaly, no ascites, and the bladder is not being particularly palpable, which may rule out a few of your differentials. You have a look at the catheter site for which he's using, and you notice some evidence of trauma. He tells you that he inserted it about 2 days ago from that place. So now that you've done your full AT assessment on that part, now it's time to formulate a plan before you will then either discuss with your seniors or you will enact some parts of it yourself. So I think when you have a patient who's largely clinically stable from what we can see in this case, but it's most likely that if he's got hematuria, he may end up being admitted and may need fluids, then you want to ensure there's IV access in order to make sure that you can put in fluids or blood products as soon as possible. Although we did mention earlier, we want to look at his previous history to see if there's any other blood tests that may have been done, for example, his FBCs or his INR. If they haven't already been taken, it might be good to do another set yourself using the usual FBCs, Urinese, do cross-matching and clotting just in case we need to transfuse some more blood to him. Of course, if he's being admitted, you want to keep him on regular observations. He's largely stable at this point, so there's no concerns from what we know. So regular observations will do at this point, 2 to 4 hourly. It's important to monitor his fluid balance and keep it in a strict mindset. We should be aiming for a urine output of roughly 30 milliliters an hour. Of course, it's not going to be exactly that, but we should be looking at it being that much, and if we see it reduced, we might have to start thinking about his kidney function and whether he's gone into an acute kidney injury or not. He mentioned that he put the catheter in 2 days ago. It might be appropriate in this situation to recatheterize him and change the catheter bag so that we can track exactly what his fluid balance is as well. We did see on the examination that his bladder was not palpable. However, in a patient with a very palpable bladder, you might be able to do a bladder scan in order to see how much urine is within the bladder and to see if the bladder is actually draining adequately on its own. The patient is saying that they are voiding, however, there's still a lot of residual urine left in the bladder. It may be the case that there's a different pathology working here. Of course, with the urine, you might want to do a urine dipstick and send that possibly for culture as well to see if the patient's brewing any kind of infection. And of course, this being a fairly complex urological case, you would be able to do all the parts from your AT assessment, act upon them, and then just get urological review to ensure that nothing is being missed out. Now, of course, as we mentioned, the patient is on apixaban for his atrial fibrillation, and of course, it's a very good reason he's on that, and we have to assess the risk that being taken off that atrial fibrillation, the apixaban, may worsen whatever we were trying to avoid. Now, in this case, he is bleeding, it's hematuria, but usually it'd be good to get a senior opinion on whether it'd be the best idea to withhold anticoagulants in this case. So, if the bladder isn't draining adequately, as we previously mentioned, sometimes that can be due to clots occurring within the bladder itself and that obstructing the flow of urine out of it. Usually, as we mentioned, a 2-way catheter can do the trick, but sometimes it's not always possible, so it may be appropriate to have a 3-way catheter instead, which may allow for adequate drainage of the bladder. A 3-way catheter is quite specialized with an outflow for urine, which is typically going to be the largest channel, an inflow channel for saline irrigation in order to push away any clots and any other debris that might be within the bladder itself, and then of course the channel which allows you to inflate the balloon to keep it stable and in place. We do have a talk on catheterization techniques which will be very useful in looking at this in more detail. So how might we grade the severity of the patient's hematuria? Now, this is taken from a fantastic paper by Adamson et al., who look at the guidelines for the diagnosis, prevention, and management of chemical and radiation-induced cystitis. In this case, of course, the patient hasn't had any kind of intervention that we know of to his bladder, but it does give you, I think, a good framework into how you might try to grade the severity of the hematuria. And of course, they split it into 4 different categories. They say non-visible hematuria, which might be picked up on a urine dipstick. Macroscopic hematuria, which is typically what you might see in the bag. Macroscopic hematuria with small clots, which is something we didn't see in this situation, but it might give you some indication as to how much the patient is bleeding and perhaps where as well. And then the worst one being gross hematuria with clots causing urinary tract obstruction requiring instrumentation or clot evacuation. So when you do consider talking to the urological service for further review, you might be able to tell them exactly where the severity of that hematuria is. Of course, if it's grade 4 and it's gross hematuria with clots and that's obstructing the patient's urinary tract, which perhaps may get even worse, it will warrant a more urgent response from the urological team as opposed to just having macroscopic hematuria, for example. So as we mentioned in our AT assessment, you want to get IV access, you might want to take a set of bloods, you might want to catheterize the patient, amongst a whole host of other things. Usually at this point, the junior doctor themselves might be on that role, and it's always a good way to get a history from the patient as well. Personally, in these kind of situations, I like to start off with a presenting complaint, and I have a nice little mnemonic called clots that helps me identify what exactly I'm looking for. So first I like to clarify. I ask the patient, when did you notice the blood? Was it only when you passed urine? Any chance it could be coming from anywhere else? What colour is it exactly? And sometimes we are unfortunately caught out by this. Have they recently eaten any beetroot? In the case that it's not actually hematuria, but rather it's just beetrooturia. Then I like to ask them, when did it typically start? Then have a look at the timing itself and say, is there always blood in the urine? Does it come and go? Have you had this before? Or does it only appear at the beginning, end, or throughout? It's important to get the timing down because then you can localize according to the urinary tract where exactly the patient might actually be bleeding from. And this will actually influence your management and how you go further with him. And of course, looking at the severity, we talked a little bit about the grading earlier. Did you pass any clots? Which will of course warrant how urgently you might need to see the patient, how urgently you might want the patient to be seen by urology in that case. Going further with the history, we want to have a look at any kind of the associated symptoms that the patient might have. Of course, always ask about pain. So do they have any pain when they pass urine? And if they have pain anywhere else, such as in the abdomen or anywhere else around the genitalia region, then you're going to want to fall back onto your old mnemonic of Socrates, where you're trying to have a look at the site, the onset, the character of the pain, whether the pain goes anywhere else, associated symptoms, alleviating factors, timing, and exacerbatory causes, as well as any severity furthermore with the pain, and see if you can tie both of these in together. Sometimes the patient may also report an increase in frequency of urination. In that case, they may have any issues with incontinence. It might be worth asking them, do they have any sudden urges to pass urine? It's good to ask them as well, how often do they get up in the night to pass urine, as this might lead you to different parts of your differential diagnosis. As we mentioned, urinary stream, it's important to know at what point are they bleeding in the urinary stream, but also whether they have any difficulty getting that stream started. Is there any dribbling at the end? And is the stream noted to be rather powerful, or is it rather weak? Then you want to have a look at more general symptoms. So, have they been unwell recently? Have they had any fever or chills? How's their appetite? Have you lost any weight? Perhaps if we're thinking of any more sinister causes within the male urinary tract. Also, have a look at the kidneys. Have you gained any weight recently? As in, are they edematous? How are their ankles swollen? Have they recently had a sore throat? Have they noticed any rashes? Having a look as well, perhaps more in the younger population, you might notice some more rare autoimmune conditions. So, pulmonary renal conditions. Have you coughed up any blood, for example? And also, it's always worth asking, have they had any trauma to the abdomen or groin area recently? So with all of that history taken, that will provide you the main content of your urological history. But it's always important to add other bits to the history in order to piece together what you might be looking for. So their previous medical history might be also very important to look at. In this case, the patient had atrial fibrillation. And from there, we might be able to ascertain a few other things from there. So we can ask specifically about any previous UTIs, any prostate, renal, bladder cancer they might have had. Although the grading was for chemical and radiation-induced cystitis, maybe that might be another cause of why they've come in with hematuria. Have they got any benign prostatic hyperplasia, any history of diabetes, any history of hypertension as well? How often do you think you change your catheter? So the patient in this case mentioned he changed his catheter every 2 days ago, but is that within his schedule or is that out of his schedule? We need to, and how much education does he have around the catheter? Is this the first time he's ever had any difficulty catheterizing himself? These are all kind of parts of the history that should be in your mind and helping you form that differential diagnosis. The drug history. So the patient mentioned he's on apixaban. Is he on any other medications? Has he changed any recently? Is he taking anything over the counter? Any allergies that he might know of? This helps you in the future when you want to administer medications and have a look and see if there's anything else you can do to optimize his therapy. Furthermore, having a look at the family history. Do any conditions run in the family at all? Ask specifically more about renal diseases. So you might, for example, have polycystic kidney disease, which can lead to hematuria, and other bleeding disorders as well. Does anyone else in the family have blood in their urine? Sometimes asymptomatic hematuria can actually just be benign and is a rather familial trait as well. And of course, have a look at more of their social history. Are they working? If that is the case, what do they do? That might lead you into clues into their occupation, such as working with industrial chemicals or dyes, and that can put them at risk for things such as bladder cancer. And of course, the usual, do you smoke and do you drink alcohol? This all leads us to have a big picture of the patient and see where clinically we can find a diagnosis that fits the overriding picture. So when taking the history, I think it's just important to take a few key points from it as well. Now, the patient themselves may actually deny that they ever had hematuria, and this is the first time it's really obvious that they've got hematuria. They might think that it's just a pink urine, and that's all it is. If they are in denial about the case, then ask them specifically what is the colour, and usually patients will tell you whatever the colour is in that part. Obviously, the presence of clots makes a glomerular cause highly unlikely, as it's probably more distal in the tract. The timing of the hematuria during the urinary stream, i.e. initially, terminally, or throughout it, can also help localize the pathology. A poor stream may consider that there is an obstructive cause. Now, of course, if you have non-visible hematuria, it may be suggestive of a glomerular disease, and in that case, you may want to get different specialties involved here. Non-visible can also be considered more pathological when it's recurring or associated with lower urinary tract symptoms. Visible hematuria is most likely going to be due to a lower urinary tract lesion, but unfortunately, as we've tried to ascertain from different parts of the history, visible hematuria has roughly about a fifth to a quarter of a chance of actually being a malignancy as well, that you might be able to spot. So having taken a good history, you've done your AT examination, there will be a whole host of differential diagnoses that will probably come to mind. Some of them that may immediately pop out to you would be things such as a urinary tract infection, renal calculi, urological malignancies such as renal cell carcinoma, transitional cell carcinoma, prostate adenocarcinoma. There may just be an injury to the urinary tract, and then you need to classify it. So is it blunt, is it penetrating, or is it iatrogenic, i.e. from previous surgery? Have a look at any other symptoms with the prostate. Is it just prostatitis, or is it benign prostatic hyperplasia? As we mentioned earlier, it may be higher up in the urinary tract, more at the kidneys. In this case, you might want to get the nephrologists involved, if especially it's a case like glomerulonephritis. And as I mentioned earlier, you can be caught out by things like beetroot, which can give you a pseudo-hematuria cause. And as well as that, you can have other medications like rivampicin or methyl-dopa that can give that mimicking colour, as well as hyperbilirubinuria as well. So the most common differential that you'll probably come across with these are the top three: urinary tract infection, a renal calculi, or some kind of urological malignancy in this case. So with the urinary tract infection, typically cystitis will increase urinary frequency, urgency, and there will be pain when you pass urine as well. The patient may present to you with fever, suprapubic pain, and urethral discharge as well. Obviously, if it's a urinary tract infection, it may be more cloudy, and the patient may describe more of a foul odour, and sometimes we can see macroscopic hematuria, but sometimes microscopic hematuria may be present as well, non-visible. Urinary tract infections on the whole tend to be more common in women, and in the elderly, don't be thrown off if the only symptom that they're presenting with is delirium, as that could lead to a cause of a UTI as well. As a F1 doctor, you always want to be on the safe side. So if the patient comes in with scoring all the markers for a septic patient, then of course sepsis is probably one of the first things that should be coming to your mind, and don't be afraid to trigger the septic pathway. It'd always be more safe to ensure and rule out that the patient has sepsis, rather than not think the patient has sepsis in this case. Of course, during a urological review, you can discuss with someone more senior if you think it might be sepsis, but it's always worth having a differential diagnosis in your mind. If you want to start the patient on antibiotics for just a simple UTI that isn't obviously something too severe, have a look in your local microbiological guidelines, but often trimethoprim 200 milligrams BD is used for simple uncomplicated UTIs as well. Having a look at renal calculi or stones, as we know, the classical presentation is the acute onset of very bad pain coming from the flank abdominal area, which is radiating into the groin, that typical loin to groin pattern that we all know about and may have some nausea and some vomiting. Of course, this is your classical presentation and won't always appear like that, but it's worth keeping in mind. What you might see as well is that the pain in renal colic is more consistent than what you might see in biliary or intestinal colic, but often there are periods of relief in which the patient just describes a more of a dull ache. More often than not, however, it is quite asymptomatic and may just be found incidentally. This typically will affect men in their 30s to their 50s as well. What you might discover as well when you talk to the urological team on review is that stones under 5 millimeters can usually pass on their own. They don't really need much intervention. Extracorporeal lithotripsy and endoscopic stone removal will be more kind of your medium-sized stones, and very rarely, if the stone's very big, then you might need open operation in order to take them out. So now that you've got your history, you've examined the patient, and you've got a few differentials in your mind, and you've kind of ruled out what you think is most likely to be the case, it might be worth ordering some investigations. So as we mentioned earlier, when you take your AT assessment, if A&E haven't already done so, it will always a good idea to get some FBCs, urinary, and some clotting just to see where the stage of the patient is at this point and see if there's anything underlying within the bloods that we know too much about. As mentioned, a urine dip for urine analysis. You might want to then send it off for a culture if you suspect there may be an infection. And obviously microscopy and sensitivity will find out what exactly is the organism that's causing the pathology, and then give the targeted antibiotics that will hopefully make the patient better in this sense. In some cases, you might want to do a urinary an ultrasound of the abdomen, having a look at the renal tract, although a CT-KUB tends to be more popular now, especially if it is for stones. A few extra investigations you might want to order, so urine cytology and cystoscopy if you suspect it be a bladder cancer, abdominal x-ray if you think it is indicated, especially for those in stones. And as we mentioned earlier, if we think that we are suspecting a glomerulonephritis or some other kind of nephrological disease, then we might want to have their input, at which point they might ask for an ANCA, an ANA, or any kind of anti-glomerular basement membrane test. And then obviously when the patient goes towards them, they might do a renal biopsy to confirm whatever diagnosis they're looking for. These extra tests will typically not be within your realm as an F1, but it's worth noting, especially as we have an interest in urology, that these are the kind of things that they're thinking about and what kind of pathologies might they be looking for when they order these kind of extra tests in this part as well. So of course, hematuria is a very serious incident to occur clinically. And the NICE guidelines have got a fantastic way of being able to differentiate how we refer onwards as well. So of course, a 2-week wait referral for patients with hematuria, if it's visible and the patient's 45 years and over, and they don't have a cause for their visible hematuria without any kind of infection possible, then they need to go on the 2-week wait referral. Likewise, a visible hematuria that persists or recurs after successful treatment of a urinary tract infection, that also needs further investigation by the urological team. But on the other hand, we also can have non-visible hematuria. Patients over 60 years old with an unexplained non-visible hematuria and dysuria, as well as a raised white cell count, these also need to be investigated by the urological team on a 2-week wait referral. Non-visible hematuria can be more difficult to detect. It's not always immediately obvious if that's what we're looking for, but this is a fantastic pathway that is suggested for primary care doctors to look at as well, in ensuring that the patient is promptly seen by the urological team if appropriate, or is merely moved to another specialty such as nephrology for further assessment on their part as well. In some hospitals around the country, the urological department may hold a Haematuria Clinic. So patients who presented with hematuria can be followed up by the clinic on discharge. As the junior doctor, if you are discharging patients based on the advice of the team, then be sure to offer the patient a leaflet that informs them that this is how they will be followed up, as well as the typical safety net advice that they should drink plenty of fluids, return if they're unable to pass urine or clots, return obviously if the hematuria has darkened and is not cleared up with drinking, and return if the pain and or fever has become more uncontrolled. Typically, this clinic will involve a full history being taken, a physical examination, which may involve a rectal exam, FBCs, urinary, and clotting being taken to see where the patient is, urine analysis in order to perhaps look for any UTIs that might be the cause, any persistent UTIs, and maybe some imaging modalities such as ultrasound, CT, or flexible cystoscopy to have a better look. These are my references that I've used to have a look at the history of how we might take a history for a hematuria, the guidelines for just grading hematuria, NICE guidelines, as well as how primary care might be able to tackle this. That's it for my presentation. I hope it was helpful. Thank you very much for listening. I'm happy to take any questions.